Okay, class, welcome to your first voiceover PowerPoint. This week we're going to be focusing on the respiratory system. Very specifically to the voiceover that you're going to listen to today, we're going to focus on COPD, emphysema, and bronchitis. We will create some case studies and some practice questions to work on in class related to these three topics and the difference between emphysema and bronchitis and how they fall under that COPD umbrella. We're going to talk in lecture and class on asthma and tuberculosis. So the objectives here: apply the nursing process to the care of patients with selected respiratory disorders as discussed. Differentiate and apply complications associated with the selected disorders, apply the roles and functions of the healthcare team, describe appropriate use of pharmacological agents, and describe appropriate diagnostic tests and lab values in the care of respiratory patients. So you guys have already been through health assessment, you've already been through fundamentals. The two areas that are still important but that we're not really focusing on for content in lecture is pneumonia and influenza. So be familiar with those as well. You should have some recollection from fundamentals about those and how it affects specifically the geriatric population. Just to again reiterate the selected disorders, as I mentioned in the previous slide, this PowerPoint is really only going to focus on that COPD umbrella. Your book goes over it in much more detail, but your ATI resource book also goes into a lot more detail. So my recommendation is to read your book, listen to the voiceover about COPD, emphysema, bronchitis, and then before coming to class, review your ATI book a little bit more over that chapter. I believe it's chapter 22 in your ATI book that will go over that in a little bit more detail. You guys do have simulation coming up specific to COPD, so that's why I wanted to make sure to get this voiceover out to you so that you can get that content and you can be successful in your simulation. I'm hoping that you're looking at this slide and seeing this as a review. This should be something that you kind of got introduced to in maybe fundamentals or health assessment. This is just different oxygen therapy that you may see a patient receiving in an acute care setting or even sometimes long-term care setting. The first one on the top left is the most common. That's a nasal cannula. It is the nurse's role to know and to understand when it's appropriate to use a nasal cannula and when it's not. To communicate that to the doctor. So if the doctor has an order for maybe oxygen therapy, it's up to the nurse to decide which of the different devices is most appropriate for their patient, depending on the assessment of the patient. Nasal cannulas can only go up to 6 liters. If your patient's requiring that much oxygen, you should be planning an intervention of changing the device by which they're receiving oxygen. From nasal cannula, patients go to a simple face mask, which is there in the top middle. You have to have the know-how of how much oxygen a patient can receive on face mask, usually starting at 6 liters, because you transition from nasal cannula to face mask. No more than, I want to say 10 to 12 liters. I don't have a book in front of me with the exact numbers, but just know if your patient starts to get up to 10 to 12 liters on the face mask, it's time to start thinking about another device. The next device is a Venturi device. This one looks similar to the face mask, but it has different color tube attachments. You can change the flow on them, so you can wean the patient up and down depending on how much the flow meter tells you to do. Then the bottom left is the non-rebreather. This is for acute respiratory issues. You do not want to leave the patient on a non-rebreather mask for a long period of time. It's high flow oxygen, and they can run into complications that we'll discuss later in the PowerPoints as far as oxygen toxicity and things like that. Then the bottom right is just an example or a picture of a trach collar. So patients that have tracheas that also require oxygen They can't have nasal cannula. The trachea is replaced with a hole opening, so you can't put nasal cannula there, or face mask, or the venturi mask, or non-rebreather. So they receive their oxygen via their tracheostomy, and there's different devices and flows for that as well. So I want you to think back to your health assessment class and think about when you focused on the respiratory assessment, or start to think of an idea of what a focused respiratory assessment might look like. If you were to go into a patient's room, how would you be able to tell if the patient was having difficulty breathing? What would the signs and symptoms be? And then what other assessment findings would you want to collect to confirm your concern? So a patient that is having difficulty breathing is usually kind of in a panic mode. I don't know how many of you have ever had asthma, or had a child with asthma, or had difficulty breathing, or it's that fear of suffocation. So patients usually, when you walk into a room and they're in distress, they usually have that big-eyed, almost like a deer in the headlights, like help me kind of look. They may be really shallow, short little breaths. They may not have hardly any breaths. So you're going to do kind of a visual assessment on their respiratory rate and rhythm in depth. And then they may have color changes. They may have cyanosis in their, in their mouth and their lips. They may have bluish fingers or graying color or dusky. They could also be cool and clammy. A lot of times these patients work up a sweat with their efforts to breathe. Other vital signs you'd want to take is obviously the oxygen saturation. That will give us a quick picture of what's going on. And then listening to the lung sounds. That would be more focused. Is there wheezing? Is there crackles? Are they full of fluid? Are they diminished? Are they not able to get any air in or out? So with that information, you would be able to plan an intervention appropriate for the patient and communicate with the doctor. Here's another respiratory mnemonic for hypoxia. So this is more for those of you that are visual learners. I want to talk a little bit more about respiratory. You have to remember that the whole respiratory system, like the cardiovascular system, the whole purpose of the heart is that it's a pump. It's moving the blood where it needs to go. The respiratory system, the purpose of it is to do the gas exchange. So the blood gets moved through the respiratory system in the purpose of exchanging gas. In order for the tissues around the body to perfuse, they need oxygenated blood. Also, in breathing, it removes carbon dioxide, which we know is important from our acid-base lecture. Carbon dioxide is the major waste product of metabolism. So your cells need the oxygen in order to take part in metabolism, and then they need to release your body needs to release the carbon dioxide, which is the waste product of that metabolism. In review, the upper respiratory is different from the lower respiratory system. So as far as a little anatomy review, upper respiratory is considered nose, sinuses, pharynx, and larynx. So basically all the way to your trachea. The lower respiratory consists of trachea, the bronchi, the lobes, and anything related inside the lobes, alveoli. I also wanted to talk about this mnemonic. I want you to kind of pay attention to the difference between early symptoms of hypoxia and late symptoms, and try to understand early symptoms. If I'm just sitting here breathing, minding my business, and I have an interruption of oxygen, you would expect to have that assessment data. Someone to be restless, tachycardic, their heart's trying to compensate, right? It's trying to pump blood faster because it wants to get that oxygenated blood. Rapid breathing, difficulty breathing, agitation, anxiety, all that list, I hope would make sense to you. Then there's a difference between early signs and late signs. The main thing that I want you to focus on too, besides assessment that we already talked about, is what kind of interventions can you do at the bedside to help a patient who's in this situation, besides calling the doctor and applying oxygen. Those, I hope, are, your knee-jerk reactions. Apply oxygen and, call the doctor for help or call someone for help. So there's a list there on the left side of the mnemonic talking about position changes, identifying what the underlying problem is, understanding your assessment data and what to do with it. Anyways, I hope this kind of makes sense and helps you kind of think through a patient in respiratory distress. So we've talked about assessment, we've talked about the difference between upper respiratory, lower respiratory systems, and we've talked about how to apply oxygen or how to recognize a patient's in distress. So let's talk a little bit about complications of oxygen. So we know that a patient needs oxygen, and so I think that this is a very important lesson to learn as a new nurse. That first step in the nursing process is you're always going to assess. That should be your first thing, and there's only a handful of critical times when you don't necessarily assess first. But if you come in a room and your patient looks like they're in distress, you're going to assess before you intervene if you're following ABPI. So if you assess that the patient's oxygen saturations are 90%, you as the nurse know that the patient needs oxygen therapy. You should have an order for this. It's considered a medication. Some facilities, most facilities have protocol in place. But it is up to the nurse to understand that the patient, their signs and symptoms, and what you need to do about it. So knowing that the patient needs oxygen and then applying oxygen. It's also the nurse's role to understand how much to start at, or the term titration. That is something that you have to learn with experience and over time, and understand that each patient is different. You may have 2 patients with respiratory issues, and you're able to titrate one patient completely off oxygen, while the other patient you are titrating up for more and more because they need more oxygen. So oxygen toxicity is when O2 levels greater than 50% for more than 24 to 48 hours. So that non-rebreather that we talked about would be an example of more than 50%. Same with the Venturi mask. I think the Venturi mask goes up to, I want to say, in the 70s, so you have to be careful with that one too. Toxicity is serious, but it's not more serious than to not adequately treat hypoxemia. So there's a fine line. You have to titrate. So if your patient's needing more and more oxygen, you're communicating to the doctor. Say, hey, this morning my patient started off on 2 liters of oxygen. I had orders to titrate, and it's 2 in the afternoon, and I'm on a non-rebreather at 15 liters, and the patient's still satting in 95, 96. And you need to communicate that to the doctor, because this patient may need something different or may need a bigger intervention. So it's serious. It's easy to fix, oxygen toxicity, but it's not as serious as leaving a patient hypoxic and not adequately treating them. If the patient's hypoxic, that means there's not enough oxygen in the cells, which means tissues are hypoxic. So that can cause death and a lot of organ failure and long-term complications. So manifestations, if your patient has oxygen toxicity, they may have a cough, non-productive. They may be complaining of chest pain. They may have stomach upset, or they may have difficulty breathing. As exposure increases, vital capacity and compliance decreases. Crackles and hypovolemia or hypoxemia develop. I think that the main thing here is to know what you're assessing for. In the nursing process, I'm going to say this a lot in class, you're going to assess, you're going to diagnose, you're going to make a plan, you're going to do your interventions, and then you're going to evaluate the effectiveness of those interventions that you've done. So if you have put a patient on oxygen, you're not just going to put them on a non-rebreather and leave them. You're going to be assessing. You're going to be assessing their oxygen saturations, their lung sounds, any signs and symptoms of distress, and then you're either going to go up or down depending on how the patient responds to therapy. To avoid um, oxygen toxicity is the number one priority. Always use the lowest amount of oxygen needed to treat the patient's condition. We talked about ABGs, and we talked about ABGs knowing if the treatment was effective by frequently monitoring and interpreting those ABGs. You also should be notifying and communicating with the doctor. This patient may need a CPAP or a BiPAP, or they even may need to be intubated if they're requiring high amounts of oxygen. Oxygen-induced hypoventilation, that is when when CO2 increases gradually over time, where that number gets up into the 60s. The CO2 receptors no longer function and do not stimulate breathing. These patients breathe at a decrease on oxygen levels. They breathe by decreasing their O2 levels. So this oxygen-induced hypoventilation is very common with patients with COPD, which we'll talk about later. So these COPD patients oftentimes, because of the anatomy of their lungs and the damage to the bronchioles, they naturally retain CO2. If we give too much oxygen, it actually takes away their ability to breathe because their CO2 levels get so high. So the best interventions for this is to use low levels of oxygen. COPD patients should just be on like 1 or 2 liters, possibly on occasion 3 liters. But if they have an acute episode or acute problem, maybe you go into a patient's room that has COPD and their saturations are in the low 80s and they're having difficulty breathing, you can temporarily increase their oxygen levels in an acute situation, but then you need to make sure you wean it back down so that they don't have this oxygen-induced hypoventilation. Oxygen-induced hypoventilation turns into apnea, so then it would become a very urgent, emergent airway breathing issue. Hypoventilation can occur in the first 30 minutes of oxygen therapy. So you got to be very careful. So if you have a patient with COPD who is in respiratory distress, who you are temporarily applying higher levels of oxygen to, you need to get your doctor, the patient's doctor, involved soon and explain that to them with what's going on. Okay, so here's where we're going to apply some of that information that we've talked about. So you are the nurse, so put yourself in the role of the nurse. What are some of the components of a respiratory assessment? So I want you to be thinking of that. We've discussed it in prior slides, but see if you can kind of critically think through that and apply it. Also, what are some of the labs that can be assessed? We've talked a little bit about labs, and I would hope you would naturally lean towards an ABG as far as a lab you would anticipate for a patient with respiratory problems. And then what imaging or tests, invasive or non-invasive, would you anticipate for a patient with respiratory problems? That should include a chest x-ray. That's one of the most common diagnostics to get a quick look at the pulmonary cavity to see if there's obstruction or any big problems. Now those diagnostics can go further. A thoracentesis, which we talked about, that's for if they do a chest x-ray and they see that there's maybe fluid in the lungs causing the problem, the doctor can actually go in with a needle and pull that fluid out. We also talked, I think in diagnostics, about a bronchoscopy. That would be where they, similar to like an EGD or a TEE, they put a scope that actually goes into the bronchial area. This should be done very sterile, or as sterile as possible, as the doctor's going to be entering into the lungs with a scope. If they do that, they're able to do biopsies and more things. That's considered a more invasive procedure. So least invasive would be your chest x-ray or your oxygen saturation. Then more invasive from that would even be the arterial blood gas. Then from there it would be a thoracentesis, then bronchoscopy or lung biopsy. Okay, so we're moving into chapter 30, content, and we're going to talk a little bit about chronic airflow limitations. Also, CAL is how it can be abbreviated, and there's 3 types of diseases associated under chronic airflow limitation. The first one being asthma. Asthma is an intermittent disease and can cause major airway issues because of allergic response or inflammation response. Chronic bronchitis. Chronic bronchitis is, well, we'll get into chronic bronchitis a little bit later. And then there's emphysema. Chronic bronchitis and emphysema are 2 different things, but when combined, create the diagnosis of chronic obstructive pulmonary disease, or COPD, which unfortunately is a very common complication or disorder. I like to tell students it's when bronchitis marries emphysema, and then you're stuck with that COPD. Major complications of gas exchange for these patients. So we're first going to talk more in depth on asthma and the ins and outs of asthma, some medications used to treat asthma, complications associated with it, and then we'll move on into the bronchitis, the emphysema, and then lastly COPD. Okay, so we're going to move on to chronic bronchitis. So what are some reasons for chronic bronchitis? What did you read about in the book? If you did your study questions, you may have answered this too. So chronic bronchitis is an inflammation of the bronchi and bronchioles. It's caused by exposure to irritants, specifically or especially cigarette smoke. This is one of the most common causes. The irritant triggers inflammation, vasodilation, mucosal edema, congestion, and eventually bronchospasms. Bronchitis affects only the airway, not the alveoli. So if you were to look at a picture of the lungs, this is coming straight from the trachea into the bronchioles, and that's where the complication is. So if air can get through there, gas exchange can happen, but then the CO2 has to find a way to leave the body, and if inflammation is too much, it sometimes is hard to expel that extra air. Bronchial walls thicken and impair airflow, thus thickening along the mucus blocks. Thus thickening along with mucus blocks some of the smaller airways and narrows the larger ones. Sorry, I don't have my glasses on. I was trying to read that. Mucus provides a breeding ground for organisms and leads to chronic inflammation. Chronic bronchitis impairs airflow and gas exchange because mucus plugs and infection narrows the airway. As a result, the PO2 levels decrease, or hypoxemia, and the arterial carbon dioxide levels increase, respiratory acidosis. So just like we talked about, cells need oxygen to participate in metabolism, and if they're not getting that, and in turn, participating in metabolism breaks down and releases that carbon dioxide. So that's what's happening in gas exchange. So if that's decreased or limited, then patient can become severely respiratory acidotic. So of course the goal in any airway type issues, we want to improve gas exchange, improve perfusion, decrease inflammation, and promote cellular regulation. So for these questions, what are some reasons for chronic bronchitis? I think we addressed that. What are some of the priority nursing considerations for a patient with chronic bronchitis? So if you can see here, if it's truly an infection, they need an anti-infective of some sort, an antibiotic. They need an anti-inflammatory, and they sometimes may need something to improve the secretions or the mucus that's building up. These patients need bronchodilators to help improve that gas exchange. The gas exchange happens immediately. That's something that we want to make sure we're taking care of to improve the perfusion and cellular regeneration. Inflammation we can work on over time, but anything we can do immediately to help improve that gas exchange is important. What are some of the priority nursing interventions for a patient with chronic bronchitis? So I think we kind of touched on that too. Let me see if there's anything else in my notes. Good management. A lot of your interventions are going to be education. Good management of the disease will help improve gas exchange and improve overall health. So we want to focus on that. They may need to increase fluids to help expel some of that mucus that's there. Take medications, mucolytics of some sort, and anti-inflammatories to help with inflammation, like steroids, prevent further infection if they're prone to bronchitis. Then these patients should definitely be getting their flu shots, should definitely be doing things to promote health, not being around sick people. If this is a preschool teacher who has chronic bronchitis that keeps getting sick from kids, well then she may need to consider her work environment to help improve her health. If this person lives with a smoker or is around cigarette smoke, that's something too. Smoking cessation, I don't think we can go throughout a lecture without talking about true smoking cessation and how important it is, not just for secondhand smoke, but for those that are smoking, how important it is to quit smoking to prevent these types of complications. I really like this slide to give a good visual on what does chronic bronchitis look like. You can kind of see, I mentioned in the previous slide if you had a picture of the lungs. So this isn't really affecting the tissue that actually holds the air, but the piping or tubing or plumbing or whatever word you want to use, but the actual tubes that bring the air from the mouth through the trachea into the bronchiole that will fill the air sac. So there's a good picture of what narrowing looks like. Also, we need to talk about cilia. In this bottom left picture, you can see these little fine hair-like things. The purpose of cilia is to work like collects or keeps the airway clear of mucus and dirt. So as that's being covered with mucus, the cilia can actually die and become ineffective. Here's another good picture to show like a normal bronchus versus a chronic bronchitis type picture. It would, I would imagine, be nerve-wracking to be breathing through something so confined, so straw-like. Just the excessive mucus and the chronic inflammation and the scarring that eventually happens to the bronchioles to restrict the airflow. Okay, so we have our chronic bronchitis pneumonic. I think this one, when we are talking about emphysema, we're talking about chronic bronchitis and COPD, I think this is a really good picture to remember. The blue bloater. These patients often present dusky in color. These patients oftentimes are really struggling to breathe. The main things on here, I think it's pretty much a given for the color, the recurrent cough, hypoxia, increased CO2 because of the obstruction there, respiratory acidosis, we've talked about that, increased hemoglobin, and respiratory rate. The other things that you'll see, digital clubbing, and I do have a picture of that later that I'll show you, of digital clubbing. That's actually clubbing curvature happening in the nail bed from chronic bronchitis or chronic respiratory issues. These patients generally are retainers. Like I said, the CO2 isn't able to escape. You have to really forcefully work on your breathing exercises to get the air in and out. These patients sometimes, not always, but will be oxygen dependent as well. Just remember the main things for chronic bronchitis is to use anti-infectives or antibiotics, anti-inflammatories or steroids, and bronchodilators to help improve, and then mucolytics to help get rid of that mucus, so like a Mucinex or something like that to help clear the airway. I think I'm going to say right now on chronic bronchitis. We'll get into a lot more details with COPD. Emphysema. What are some reasons for emphysema? Emphysema is loss of lung elasticity and hyperinflation of the lung. So different from the bronchitis, this is actually affecting more alveoli. These changes result in dyspnea and need for increased respiratory rate. Most common causes are associated with smoking and chronic exposure to other inhaled particles. This would be wood smoke or fuels or certain chemicals. An increased amount of firefighters oftentimes have emphysema from smoke. An increased amount of air is trapped in the lungs, and this overstretches the alveoli because it's trapped in there and it's not able to escape, so it kind of makes the air-filled spaces, the alveoli, bubble. It can collapse small bronchioles, and there's a picture a little bit later that will make more sense. These changes greatly increase the work of breathing. The hyperinflated lungs, because they're so inflated, can actually flatten a patient's diaphragm, weakening the effectiveness of their muscles. These patients then need more accessory muscles. You'll see them breathing when they're breathing using muscles in their neck or in their chest wall or their abdomen. The increased workload increases the need for oxygen, making the patient have air hunger sensation. So priority nursing interventions for this patient would include breathing techniques, education, positioning, relaxation techniques, respiratory support, and I think I already said patient education. So let's go on to the next slide. We'll kind of give you a visual of what emphysema looks like, and then we have a mnemonic to kind of better understand emphysema. Okay, so emphysema gradually damages the air sacs or the alveoli in your lungs. So here on the left shows a healthy, normal alveoli or air sacs. It looks kind of like skinny broccoli or almost like asparagus-y. And then the middle one is more like a cauliflower look. So those air sacs have lost their elasticity, so they're just puffed up, full of air. So they're not able to open and release to do that gas exchange. And then there's another type there on the right. I don't think we're going to go into detail with that. We won't go into detail with that for testing purposes. Just know what's happening anatomically, what's actually happening. Emphysema is one of several diseases known collectively as chronic obstructive pulmonary disease, which we talked about. Smoking is a leading cause to emphysema. So that's basically what emphysema is. Bronchitis affects the bronchioles or the tubes that bring air in, and emphysema impairs the sacs that actually exchange the air. So let's go on to the mnemonic on the next slide so you can see a little bit more about emphysema. So opposite of the blue bloater, which the blue bloaters are chronic bronchitis, we have our emphysema, which is our pink puffer. This person also is at risk of retaining CO2 because of the inability to exchange the gas. They may or may not have a lot of blue cyanotic looks. These patients, if they haven't been taught, they should be taught about pursed-lip breathing. These patients live chronically with activity intolerance because of their inability to exchange gas. So these patients often are thin in appearance. They're usually anxious. My experience with patients with respiratory problems is they love to talk, which is so pitiful because they're like, I just want to tell them, just save your oxygen because they look so miserable. These patients use their accessory muscles naturally. That's a chronic thing that they do. We teach about acute respiratory issues and using accessory muscles. This turns into a chronic issue. And then see how this pink puffer has a barrel around his chest? That represents the changes in the lung and in the diaphragm because the expansion of the lungs because of the scarring and the the loss of elasticity. So they have kind of a barrel chest. Like your average person, their depth to width ratio of their chest is, I don't know, 2 to 1, and then someone like this is like a 1 to 1. So they're as wide as they are deep around the chest. Notice too, this patient doesn't have oxygen therapy. That doesn't necessarily help. That can actually make them worse because they're already retaining so much CO2. Okay, so now we have talked some on emphysema. So in review, emphysema and chronic bronchitis is what causes chronic obstructive pulmonary disease. Pulmonary emphysema involves loss of lung elasticity and hyperinflation of the lung. Then bronchitis is an inflammation of the bronchi and bronchioles caused by chronic exposure to irritants, specifically or especially tobacco smoke, triggering inflammation and vasodilation, congestion, mucosal edema, and bronchospasms. So COPD, like I said, is when chronic bronchitis and emphysema marry. They get COPD. So what are some of the reasons for COPD we talked about? Most common, specifically in the United States, is cigarette smoke. I know the other day, me and my husband were driving down the road and someone was smoking, and my husband said, "People still smoke? That's so 1990." And it just made me laugh because that's true. It's something that is research and as time has gone on, we know it's bad for us, and it's a preventable measure for further complications. So what are some of the priority nursing considerations for a patient with COPD? Based on the video that you guys just watched on the previous slide, you know that these patients can get fatigued. They have to. It just takes them twice as long to do things that someone doesn't have COPD. Walking up and down stairs, getting ready, making food, eating, all of those things. These patients have ineffective breathing pattern related to both the chronic bronchitis and the emphysema. Decreased cardiac output, impaired memory, impaired gas exchange, ineffective airway clearance, and they're at risk for falls. So those are some priority nursing considerations for these patients. So what would you be considering? So we get our assessment, we have our assessment data, we make a plan or we diagnose based on our nursing considerations. So what kind of interventions or what type of priority interventions do we want to anticipate for this patient? Improving their gas exchange and airway clearance. So these patients still need bronchodilators. They'll need like rescue inhalers. They're still going to be probably on chronic steroid use. They may need oxygen therapy. They probably need a good respiratory assessment. So lung sounds, respiratory rate, depth, rhythm, oxygen saturations, assessing for blue or discoloration, clubbing, those types of things. Administer oxygen, and remember, like we talked about before in administering oxygen, these patients are retainers. If we give them too much oxygen, it can actually take away their drive to breathe. So COPD patients who are on high levels of oxygen therapy are at risk of a respiratory arrest. These patients need to practice deep breathing and coughing to help remove some of those extra secretions. They need to make sure that they have adequate hydration to help that mucus become mobile, so they're not dehydrated and not able to expel the mucus. They may need chest physiotherapy. That's something that respiratory therapists are trained in doing, where they use kind of a tapping motion over their lung fields to kind of break up any mucus in there. um, pre- preventing further infections. These patients are um, they are a fragile population. If they get an upper respiratory infection on top of the condition they already have, they oftentimes will need to be hospitalized. Whereas, a healthy person gets the flu, they don't need hospitalization. A COPD patient that gets a flu or upper respiratory infection might need to be hospitalized. We're going to anticipate giving them their medications: bronchodilators, steroids, anti-inflammatories, mucolytics, oxygen. They may need to do SPNs, or you would anticipate that these patients have respiratory therapy working with them in the hospital, or that they have orders for respiratory therapy for breathing treatments. You're going to want to listen to their lung sounds often before breathing treatments, after breathing treatments. You're going to want to be assessing their oxygen saturations often. It would not be uncommon for this type of patient to have lower than normal oxygen saturations. These patients may be in the low 90s, and that's okay. That's where the doctor actually wants them to be, because of their chronic CO2 retention and their risk for respiratory acidosis. They're okay with the lower oxygen levels as a way of compensating for that. Improving their nutrition because of the long use of steroids and their inability to really do a lot for themselves. Their nutrition isn't usually the best. They need small, frequent meals that are high calorie. They sometimes can't breathe well enough to sit down and just eat a large meal. So these patients need their nutrition addressed to help with healing, helping with activity levels, helping with muscle. They need their muscles to breathe. All their accessory muscles they're using. They need energy so that they're able to get through their day. So nutrition is a really big part of interventions for these patients. So COPD is classified from mild to severe, and it affects gas exchange and oxygenation of all tissues. Arterial blood gases identify oxygenation, ventilation, and acid-base status. So you would expect a patient who's coming in with respiratory complications to have frequent ABGs. This mnemonic here, this is called tripod positioning. So see how he kind of is bracing himself on the table there to open the lung expansion in his back. The biggest part of your lung fields are across the surface of your back. So these patients often need to be positioned in a way where they have best chance of gas exchange. They easily get tired. We talked about that. And they're more prone to infections because they don't have the cilia and their bronchioles working in their favor, because they are scarred or obstructed. So pathogens are more likely to get into their lungs or into their airway. They chronically use their accessory muscles. Orthopneic, that's difficulty breathing when laying down. Again, when discussing the lung fields, if they're laying on their back, they can get short of breath pretty easily. Wheezing, the pursed lip breathing, chronic coughing, the barrel chest, the difficulty breathing. I think we talked about all of those. Prolonged expiratory times. They usually can get the air in, they can't get the air out. That's usually the harder part. Digital clubbing, cor pulmonale, that's more late stages that eventually can lead to heart failure. These patients notoriously are thin in appearance because their activity intolerance, their inability to get proper nutrition. I just like how this guy's still has a cigarette sitting there on the bedside table. So this is emphysema meeting bronchitis for chronic bronchitis for COPD, which is a chronic airflow limitation. Good management strategies help maintain adequate oxygen and tissue perfusion, as well as overall health. So if managed well early on, their likelihood for rapid decline is less likely, better outcomes, I guess I should say. wanted to tell you, before any interventions, your first step in your nursing process, you want to assess the patient to determine their breathing pattern, especially the rate, rhythm, depth, use of accessory muscles. I think we talked about all that. Ensure proper oxygen flow rate. We talked about that. Not giving too much oxygen, that they may need a little, but you're assessing. You assess their O2 saturations, you assess their lungs, you do a focused assessment, you initiate oxygen, and you reassess. And you continue to reassess. These patients need frequent respiratory assessments. You're going to teach your patient to monitor or to do pursed lip breathing, diaphragm breathing, coughing, deep breathing, positioning, relaxation. We talked about that. I think I covered everything in my notes. That's one thing I didn't talk about with oxygen therapy. Oxygen therapy and open flames do not go together. So I should have remembered by looking at this picture. See how he's wearing his oxygen, and see how he has a cigarette burning there next to him. I have actually had a patient, a younger patient in the trauma ICU that was in for, I don't know, some type of accident, and his was on oxygen therapy, and had his friends come in and bring him a cigarette that he lit and started smoking, and the oxygen did actually blow up, and he had facial burns. So you really want to make sure that you are educating that. Another important thing about oxygen therapy is oftentimes these patients need their oxygen, if they're chronic use, maybe they wear oxygen at home, they oftentimes need their oxygen humidified because it can really dry out their nasal passages and cause nosebleeds and other complications. If you have a COPD patient in the hospital with respiratory problems, you want to anticipate frequent blood gases and knowing how to interpret those and to understand what they mean or how to communicate with the doctor to help guide your interventions and treatments. Lung transplantation and lung reduction surgery are surgical options. I think that's all I have to say about COPD. You may need to enlarge this picture a little bit, but here's Jeremy Renner, and you can see on his hand there on the shoulder of this lady he's with, clubbing in his fingers from chronic cigarette smoking. And I think, he's off the Avengers. Which one is he? Hawkeye? I don't know. But, yeah, chronic cigarette smoking. Educate on smoking cessation, the importance of quitting, avoiding it, use a patch. It's not so much the nicotine as the damage of the inhalation to the lungs.